Okay, so this video is going to discuss chapter 33, which is drugs for bipolar, medications for bipolar. And again, just like the other chapters, it's sort of going to start out sort of a pharmacotherapy theory as to why some of these medications work. So people don't really understand exactly why people become manic, but we have a pretty good idea because of the success of some of these medications. But if you think about it logically, if you think about depression and mania existing on two different poles, whereas depression was the deficiency of amines, then the opposite of that direction is going to be an overproduction of amines. So that's essentially sort of where it is. It's considered to be an overproduction of glutamate, norepinephrine, dopamine, alterations in serotonin, which is which makes sense, right? But in particular with the glutamate, is one thing I want to point out is that GABA and glutamate sort of have an opposite effect on each other. So if glutamate goes up, then GABA is usually low. If GABA goes up, then glutamate's low. So the reason why that I bring that up is that mood stabilizers, or actually otherwise known as anticonvulsants or anti-epileptics, all right? So with regard to seizure, one of the things that causes it primarily is going to be an excess or a spike in glutamate. So the reason why that we give benzodiazepines for sort of rescue medications for seizures is because it induces GABA. So GABA will actually bring down glutamate. So understanding sort of that relationship, I think, is important, and also then understanding that one of the primary reasons behind bipolar is that it's really going to be sort of an ion channel disruption. So chloride in particular is one of the main things that we sort of manipulate with lithium, Depakote, all these things. So as more negative things go in, you start to upset the action potential, assuming you guys are familiar with that, and depolarization and things like that. So if you have too many negatives going in, then the action potential can't complete its cycle, right? So you actually have it acting very frantic, and it's not able to complete sort of its cycle. So you're going to get a lot of excess and deregulation. So the idea behind lithium and really all of the bipolar medications is that what we're trying to do is actually reset that action potential. So you've got a lot more of the chloride in there, which is causing the erratic sort of production, receptivity, etc. And we're trying to manipulate the calcium, which is a positive. So calcium positive, chloride is a negative. You know about that balance. The other thing to keep in mind is that calcium is particularly related to glutamate or the NMDA receptors. I mentioned that in the antipsychotic about the Zyprexa. So understanding that the regulation of calcium tends to affect more with the glutamate, it tends to have more of effect on GABA. So if you see those things, you can probably break it down into saying, okay, well, I'm pretty sure if I'm dealing with calcium, that I'm probably going to be dealing with glutamate, and by extension, you're probably dealing with GABA. So it's important to keep that in mind. That's primarily what we're manipulating. But GABA has a tendency to apply a braking system to all sort of neurochemicals. So it is the inhibiting neurochemical. So if norepinephrine and dopamine and things are up, GABA can kind of bring those things down and sort of restabilize them. So that's the basic theory behind these things. And again, I'm not going to cover the bipolar medications extensively, but I do think that that's an important concept. The other thing is that I just remember that with the bipolar medications that most of them are going to require therapeutic index, and are going to require blood levels being drawn, in particular lithium, Depakote or valproic acid, carbamazepine or Tegretol. Those things require blood draws. Most of the time, it's when you first initiate them, it's the first week. Really, ideally, you would like to check them weekly, but that's not always feasible in an outpatient setting. So just know that with lithium, in particular, when you start that the first 5 days, you want to get a measurement of that. The serum levels are 0.6 to 1.2. For geriatrics, it's a little bit lower, usually about 0.45 to 0.5, depending on the severity. And you may actually see some people that have severe bipolar managed somewhere about 1.3 and 1.4. But anything over about 1.5, you're actually going to start getting to be lithium toxic. Now, the other thing that you need to understand about lithium, and this makes sense, is that it exists naturally in the periodic table, but it also replaces sodium in the body. So everything that you know about sodium and every system that it affects, you can basically apply that to lithium. So if you have an increase of that, then the symptoms are very similar to hypernatremia. So if you have an excess amount of lithium, then you want to think about kidneys. Kidneys, are probably going to shut down, and that's where it's excreted from. So things to think about with lithium are ways that you start to lose water is going to increase the concentration of lithium in the same way that it's going to increase the concentration of salt, right? So people that are highly active, maybe you're treating an adolescent that's 19 or 20 years old playing competitive sports, you want to think about how much sweating he's going to be doing, and then adjust your lithium accordingly to that. And you probably actually want to do a couple more lithium draws just to make sure they're in the therapeutic range. The common side effects of lithium is nausea, vomiting, diarrhea, polyuria, polydipsia, tremor, fatigue. Again, think about sodium. You can pretty much mirror the two. It is a teratogenic agent, so you cannot use it in pregnancy. In patients, you may see it where if someone was on lithium when they conceive, sometimes they will continue to keep them on lithium. That again is a decision that you shouldn't have to be making, but you may see it from time to time. Carbamazepine, its therapeutic levels are between 4 and 12. It's metabolized by the P450 enzymes. But the thing to know about carbamazepine is you can develop blood dyscrasias off of that. It's also teratogenic as well. But so you want to watch white blood cell count. You want to watch absolute neutrophil count when dealing with Tegretol. You also want to look for the same thing that you're going to see in well, let me back up. So we're going to another medication, which is Depakote. Depakote is probably, even though the book tells you that lithium is gold standard or primary choice, it's not really the case anymore. Really, Depakote and Tegretol are probably the two that you're going to see more often. Depakote is very, very sedating. It's very, very useful for people that are acutely psychotic. So you can give that to someone who comes in fluidly manic. Whereas with lithium, it's a little bit more of a maintenance. So it's not really good for acute mania, but it is good once you get the mania under control. You can then sort of prescribe lithium. And it does a very good job of keeping people from sort of relapsing into what we would call a manic state. Depakote is very good. It's one of the ones that I go to, particularly with someone that is bipolar 1, that actually has those extreme sort of manic episodes. But the other thing with it is you have to be careful with is two things. One is it's highly sedating, which sometimes in the clinical setting, much like we did with the SSRIs, we can use that to our benefit. So if you have someone that can't sleep and that maybe have some irritability and things like that, Depakote's a pretty good medicine to prescribe at nighttime. But again, remember the therapeutic index. Second to that is you really don't want to prescribe Depakote to someone that is an alcoholic. So it's going to be one of a, probably not a contraindicated relationship, but for the purposes of this, it is, because it is metabolized extensively by the liver. And if someone has hepatitis or they have other drinking cirrhosis, whatever, this medication here can be very harmful for their liver. And really, of course, it develops. It's hard to predict the therapeutic levels when you're dealing with something like that. Lamotrigine or Lamictal is a medication that is pretty good for, it actually tends to be better for personality disorders like borderline and antisocial personality disorders, which again is not something that is normally considered to be treatable. But if you see someone that's on Lamictal or Lamotrigine, I wouldn't assume necessarily that they're bipolar. They may be treating some type of treatment-resistant depression because it works pretty well for that, or they may be treating some type of personality disorder with specific features of irritability and mood lability. Now, there's a lot of confusion, and I know you guys won't make this mistake, but being happy and then being sad, over the course of like a couple of minutes is not bipolar. So these are extreme oscillations. In order to be manic, you have distractibility, sometimes psychosis, indiscretions, grandiosity, flight of ideas. Your appetite is usually suppressed because of, again, the increase in all the amines, like norepinephrine, things that are appetite suppressants. And then talkativeness is one of the things, and then lack of sleep. So people that are manic they're going to have slept 0 hours of sleep or maybe 30 minutes, and they say that they're upset that they slept that much. So again, sometimes when you see Lamictal or Lamotrigine, it's not always for severe bipolar. It does pretty good, much like lithium does, in terms of its maintenance of bipolar. One thing to keep in mind with Lamotrigine is you don't have to do therapeutic blood levels with it as you have to do with lithium, Depakote, and Tegretol, but if you have to taper it very carefully. So, for instance, for the first week, you start on 25 milligrams for 7 days. Then, if there's no response, or excuse me, if there's no side effects, then you increase it from 25 to 50. You wait a week. If there's no side effects, then you increase it 50. So you double it each time, with the target dose being about 150 to 200. The thing about it is, if they miss a couple of days of dosage, you can't just go back to, like, so say they were taking 150 for 3 or 4 months, and then they miss 3 or 4 days. They can't go back to taking the 150, because there actually tends to be a pretty pronounced sort of reaction to that. In particular, you have to sort of look for like rashes and allergies. One of the ones that we look for is Stevens-Johnson syndrome, which is a systemic reaction to the medication, which if you just discontinue the medicine, then it tends to resolve. But if it's allowed to persist, then it actually can cause a sloughing of the skin, and skin peels off, which is much different and very upsetting, obviously, for the patient. So just kind of keep that in mind. Just like all of the rest of them, I mean, you're let's see. Oxcarbazepine, which is triliptal, is a chemical cousin to Tegretol. So the benefit to triliptal or oxcarbazepine is it doesn't require a therapeutic blood level. So if you have a patient that you have issues with compliancy, and you're not sure that they're actually going to take the medicine as prescribed, or they may take too much, then you're not going to want to go towards a medicine that has a near therapeutic index, like your lithiums, like your depakotes, like your tegretols, or the lamotrigines, where compliance is going to be important. But you can use something like oxcarbazepine, which does not require follow-up appointments in terms of blood draws, but I will say that it's not as effective as the other ones. So definitely take into consideration the severity of the bipolar when making that determination. Then you have things like gabapentin. That is actually sort of a catch-all medication. It has a lot of different uses. I'm actually a big fan of gabapentin in a lot of different ways. In particular, we had talked about sort of the relationship with benzodiazepines, with GABA, and we know that benzodiazepines increases GABA. We also know that in alcohol, and we'll talk about this in the anti-anxiety stuff, that alcohol also increases GABA. So what gabapentin does, which is unique that a lot of people don't know in the primary care settings, it's utilized a lot, is that people that are trying to cut down on alcohol and that are having difficulty sleeping based on the fact that their body's probably waking them up due to subtle withdrawals. Gabapentin actually is the only medication that's been proven to actually help those individuals sleep. So in the same way that it's going to add some gabapentin, it's going to re-regulate those GABAergic systems, it's going to sort of put a braking mechanism on glutamate, which is one of the reasons that people have seizures when they go into alcohol withdrawals, is a spike in glutamate. So in the same way that we had mentioned that manipulating GABA in bipolar is useful, gabapentin does that, but it does so in a less addictive way than like a benzodiazepine would do. We tend to not use benzos in people that are bipolar unless it's sort of severe, but it's not all that uncommon for someone that does slip into a manic state for them to be on benzos for 2 to 4 weeks, just to kind of get, just to allow the opportunity for the depakote or the tegretol to have its effect, because it does build up over time. Which is why you have the therapeutic blood levels. It doesn't hit those instantaneously, but the benzos can provide some type of protection for the patient and some type of control over the mania, and hopefully allow them to sleep a little bit to sort of restore their brain. So you may see that, but it is not considered to be a long-term treatment plan with benzos in people that are bipolar. Another one that you may see is tegretol or topiramate. Really, we don't use that a lot for bipolar. It's okay for maintenance. Most of the time, if you see that, it's people that are having some type of migraines, maybe some personality disorders. It kind of functions in the same capacity as Lamictal or lamotrigine does for that. But really, like I said, the book and the PowerPoints do a pretty good job of covering these things, so I didn't want to spend a ton of time on it, but just know that they know the ones that require the therapeutic blood levels, know what those ranges are, and then know what symptoms of toxicity are. And I think overall you'll be fine.